We'll give everyone a few seconds to filter in. Okay, welcome everyone. Thank you for joining us. Tonight we are very lucky to be joined by Kelly Lazaration from the National Donor Marrow Program, formerly known as Be the Match, Dr. Troy Lund from the University of Minnesota, and Kiomara Gonzalez to share her parent perspective with us today as we talk about donor search and selection. I'm Felicity Emerson. I'm the scientific director of ALD Connect, and I'm happy to be moderating today. And before we turn it over to Dr. Lund, just quickly read our disclaimer. This webinar is for informational purposes only. The discussion is not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect that you or a family member are ill, seek professional medical attention immediately. ALD Connect and our partner speakers do not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned during this webinar. And always consult your healthcare provider with any questions regarding adrenoleukodystrophy. So with that, I'll turn it over to Dr. Lund to get us started.
Alrighty, thank you. Did my first slide come up? Oh, great. Yeah, so I'm dealing with 3 monitors, so glad it came up correctly. So I'm just going to have like a few 4 or 5 introductory slides to remind us all what adrenoleukodystrophy is before we talk about search. So as you know, ALD is an X-linked condition. The mutations are found in the ABCD1 gene. It codes for a protein, which goes by a different name called ALDP. It affects the body's ability to break down very long-chain fatty acids, and therefore those very long-chain fatty acids accumulate in the brain, the adrenal glands, and the spinal cord, where they have the most devastating effects and consequences. The buildup leads to progressive damage over time. Yeah. Let's see, forward. There we go. So cerebral ALD, it's a form of ALD that affects the brain, specifically the white matter. The immune system is involved with this inflammation, whether it's the initiator or the consequence of it is still not clear to us. Ultimately, it leads to a small amount of demyelination that can be progressive over time. Myelin, as a reminder, is a protective coating around your nerves. Without it, the brain signals really don't function properly. And severe symptoms in persons with cerebral disease include changes in behavior or learning, vision or hearing problems, and loss of motor function. How does it progress? It often starts silently on the MRI, way before symptoms appear, actually. So it starts as a very small, sometimes just little one dot of disease, and it spreads centripetally. So it's like a balloon that spreads out through the brain. Once it's active, the inflammation can then take off rapidly. Progression, as I mentioned, can lead to neurologic decline and ultimately could lead to loss of independence and death. We use MRIs that are scored per a scoring system invented by Dr. Less, the Less score, and it helps us keep track of disease severity and progression. So why does hematopoietic cell transplant work in cerebral ALD? And this is the term I use, is hematopoietic cell transplant, but you could say stem cell, you could say cord blood, you could say mobilized peripheral blood. I just kind of use the most basic term because they're all hematopoietic cells to some extent. They're not all stem cells, but they're all cells. So we provide healthy donor cells, an allotransplant from an unrelated donor. There's also an autotransplant where you donate your own cells and then gene therapy is used to add the corrected gene into those cells that are ultimately given back to you after chemotherapy. So In either case, the cells travel through the bloodstream, they enter the brain, and they become something like a microglia cell in the brain, and they supply, first of all, the ALDP protein, which is missing in the disease state, and then they help deregulate or downregulate the inflammation going on in the brain, and you can get disease arrest fairly quickly. The fastest we can see it on MRI is about 30 days after transplant. Ultimately, we believe the process takes months for true stabilization, though, probably 6 months. Uh, it stops the progression, but if there's damage beforehand, that we can't do. So we don't see any remyelination or repair of existing damage. So that's why timing matters. Transplant is most effective when done very early in the disease. But if you do it too early, for instance, if you don't have disease, you might be taking an unnecessary risk in transplant. And since we still use pretty powerful chemotherapy that has some side effects, including infertility, we don't necessarily put patients with ALD through this unnecessarily. If you do it too late in disease, the damage is maybe already too severe to have any, for the transplant to have any impact. And the goal is to treat the disease during the active but early phase for the best possible outcome. So that's the end of my 5 slides. I will now stop sharing and turn it over.
All right, I'll take it from here. While I'm getting my slides pulled up, I want to apologize in advance. I have a really bad cough that I'm fighting, and it will be amazing if I make it through this without coughing, but I will do my best. So my name is Kelly Lazration, and I work at the NMDP on the team that supports transplant centers in their search for donors for their patients in need of transplant. And so I'm going to be covering two topics here. HLA basics. So what is HLA? Why does it matter for transplant? And then when you know you're a transplant candidate, what does that donor selection process look like and how are those decisions made? But first, I want to touch on who NMDP is in case any of you are not familiar. So most people know us as a national bone marrow registry, but we really do so much more than that. We are a leader in cell therapy. So our mission is to save lives through cell therapy. And today, not every patient gets the transplant that they need. And so our vision is to work every day to create a world where every patient can receive their life-saving cell therapy. And the registry was started with Laura Graves, who was a young child diagnosed with leukemia, and she received the first unrelated bone marrow transplant. So through the support of her family, other patient families, physicians, and Congress, this National Registry of Volunteer Donors was started. It was at one time thought that nobody would be willing to volunteer to donate their bone marrow to somebody that they don't know, but it turns out there are millions of people who are willing to do just that. So I mentioned that we do a lot more than just run a registry, but it does all start with registering donors. So registering donors is very simple. All they need to do is swab their cheek and mail that swab in to NMDP's biorepository, where we store those samples, and we also ship them out to a contract lab to do HLA typing. So once we receive the HLA typing results on the donors that are joining the registry, those individuals begin to show up on the registry for searching patients. And so then that takes us to the matching process. So my team is involved in helping to match potential donors to patients in need. But we also facilitate the transplant process, which is pretty amazing. There are a lot of moving parts. Once a donor is identified as being one that a physician would like to use for their patient, NMDP calls that donor, talks them through the process. They go through a health history questionnaire because they need to make sure it's safe for that individual to donate and also to make sure it's safe for the patient to receive that donor's cells. And so if that donor is ultimately decided to be, the primary donor for the patient, we have a logistics team that sends out a volunteer courier to wherever the donor is located. So once those cells are collected, that volunteer courier then transports the product to wherever the patient is in the country, and then that patient can be infused with the healthy donor cells. NMDP also has an entire research arm of the organization where we're generating new knowledge to improve outcomes and experience. So that research arm is called CIBMTR. Excuse me. This is the Center for International Blood and Marrow Transplant Research, and it's a collaboration between NMDP and the Medical College of Wisconsin. And we are really lucky to have this in the US. We have millions of dollars invested annually in research, so many ongoing studies and clinical trials happening every year, and over 300 transplant centers participate in research. Some of the exciting research coming out of CIBMTR right now is related to reducing a post-transplant complication called GVHD, or graft versus host disease. And this research is finding that patients who don't have a perfect match can still have really good transplant outcomes when they receive cells from a mismatched donor. So this is most helpful for ethnically diverse patients who are much less likely to find a perfect match on the registry. So today, just about any patient should be able to find a donor for transplant. So let's jump into some HLA basics. So starting with the biology of HLA, starting with the DNA. So this is the body's blueprint. You get half of each of your parents' DNA. Then you have genes. So a gene is just a section of DNA, and a gene can have many different variations. These variations are called alleles. You'll hear me refer to HLA alleles later on. And then we have chromosomes. So chromosomes are just made up of many, many different genes. And you inherit a total of 46 chromosomes, 23 from each parent. So this DNA is stored in the nucleus, and it encodes the antigens that are found, sorry about that, found on the cell surface. So what is HLA? It stands for human leukocyte antigen. To put it simply, human leukocyte antigens are proteins that are found on the surface of white blood cells and other cells in the human body. So like I mentioned, you have the HLA genes in the nucleus, and they encode the antigens or the HLA proteins on the cell surface. So what do those HLA proteins do? They play a really important role in our immune defense by binding and presenting small pieces of proteins, which are called peptides, to the immune system. And this process allows the immune system to distinguish self-peptides, which are made by our own cells, from non-self peptides, which are made by tumor cells or pathogens such as viruses and bacteria. So in other words, HLA allows the immune system to distinguish between the body's own cells and potential invaders. So you can probably guess why this is important for transplant. When cells see each other as self, the donor cells can grow in the patient's body, and this is called engraftment. There are fewer complications post-transplant, and this leads to better patient outcomes. However, if two people carry different HLA proteins, the immune cells from one person will attack the other person's cells. So this is because the immune cells recognize the other individual's HLA peptide complexes as non-self, and they initiate attacks on those cells as if they're being invaded by pathogens. So if the patient's immune cells attack the donor cells, this can result in graft rejection. Now, graft rejection is not the same as graft failure, which results from the inability of the graft to take hold and grow to form a new immune system for the patient. And then on the other hand, if the donor's immune cells attack the patient's healthy cells, this can result in graft versus host disease, which is a really serious complication of transplant and leads to worse patient outcomes. So in order for transplant to be successful, the patient and donor stem cells should be somewhat closely matched for their HLA proteins to reduce the risk of graft rejection and GVHD. So I'm going to go through a little bit of terminology. I mentioned that people inherit 23 pairs of chromosomes. So the HLA alleles or loci are on chromosome 6. And a locus is really just a location on the chromosome. Now, a haplotype in genetics is the set of alleles that are inherited from each parent. So this can refer to a specific combination of alleles at adjacent locations on the chromosome that are transmitted together from parents to offspring. So the HLA haplotype in hematopoietic cell transplant commonly includes 6 loci, A, B, C, DR, DQ, and DP, and these are transmitted together on chromosome 6. Now, generally, most transplant centers look at 4 or 5 loci to match. So A, B, C, DR, and or DQ. So you might hear your physician refer to a donor as an 8 of 8 match or a 10 of 10 match, even a 12 of 12 match. So the reason for that is you get a pair of HLA haplotypes, one from mom and one from dad. So the two haplotypes together form a genotype. And the genotype is really just a person's genetic makeup or a pair of haplotypes. So you can see you're going to have 2 HLA-A alleles, 2 HLA-B alleles, and so on. And so that's how you get the 8 out of 8 or the 10 out of 10 or the 12 out of 12. Now, one of the things that makes matching really difficult is just the large number of HLA alleles. HLA genes are highly polymorphic, meaning that there are many possible alleles at each locus. So you can see here there are thousands of different allele possibilities, and more new alleles from people around the world are discovered in HLA labs every day. Now, some HLA alleles are very frequent across all patient populations, and others are much more rare. So there might be people on this call who all share the A0201 allele because that's a pretty common HLA allele across all patient populations. However, there might not be anybody on the call who has a more rare A0321 allele, for example. And so that's why it can be very difficult to find another individual out there who shares exactly the same HLA alleles as you. So we've already talked about one reason why HLA matching is difficult, just the large number of HLA alleles that exist. But another thing that contributes is the global diversity of HLA. So why is there so much diversity in HLA? As a species, humans are better able to survive external threats such as bacteria or viruses or toxins, etc., the more diverse our immune system is. So the variations in HLA actually protect our immune system, allowing us to better survive external threats. However, this also leads to matching being more difficult. And then finally, the HLA typing that we have for potential donors on the registry can also make matching a bit challenging. When a donor is not yet fully typed, we have to make a guess. This is becoming less of a challenge as donors age off of the registry and new donors get added to the registry with full typing when they join. But many years ago, we didn't do full HLA typing on new donors when they joined the registry because HLA typing was very expensive at the time. And so you would have donors, you still have donors on the registry today that only have partial typing. But today, when new donors join, it's gotten much cheaper. So we just do the full HLA typing on every donor who joins the registry. So, like I mentioned, this is a little bit less of an issue. So, speaking of donors on the registry, I'll kind of shift over to talking a little bit about donor selection. So as you know, and as Dr. Lund mentioned, transplants are used to treat certain cancers, blood disorders, and immune system conditions. And the goal is to replace those unhealthy or missing cells with healthy ones that can do the work that the body needs. And so there are many different cancers and diseases that are treated by transplant, some of which are listed here, different leukemias and lymphomas, bone marrow failure syndromes like aplastic anemia. You see ALD listed here, of course, so different inherited immune disorders and different genetic and metabolic conditions. So when a patient needs a transplant, there are different potential donor options to consider. And these options are really on a spectrum, not necessarily a hierarchy. So a patient is usually considering both related and unrelated donors. Now, related donors are not always an option for every patient, depending on different factors. But typically, the physician is looking at both potentially related and unrelated options. So among related donors, we're usually looking at matched sibling donors or haploidentical donors, which are half match. And among unrelated donors, we typically start by looking for 8 of 8 matched unrelated donor, but if there aren't any options, we're also looking at 7 of 8 mismatched unrelated donors, as well as cord blood, which is an excellent option, especially for pediatric patients, because cell dose is less of an issue. But I think the takeaway here is that there's no single best donor type. It really is dependent on the patient case. So historically, a patient needed to have a perfect match to receive a transplant. So during that time, it was really only HLA that was being factored into the decision. But today, almost every patient should be able to find a donor. However, we don't yet have a perfect study that has been done that is able to compare every donor attribute to determine who is the very best for any given patient. And so, really, it's a balance of many different factors. Physicians are looking at HLA match, 8 of 8s versus 7 of 8s. They're looking at donor age. There's really strong evidence that younger donors are associated with better outcomes. Availability is really important. You need to find a donor that is actually available on the patient's timeline. You heard Dr. Lund mention that you want to get the transplant on that patient's timeline. It's really important that you don't delay. And so finding a donor that is available during that time frame is important. And then that's also related to where these donors are actually located. Are they in the US? Are they international? Center protocols matter. Not every transplant center does cord transplant. And so if you don't have the match that you need with an unrelated donor, cord transplant is almost always an option. So you want to find a transplant center who does cord transplants. I just think it's important to note that when different decisions are made by different physicians, it's not necessarily disagreement about the science. It's really just their own clinical judgment because we don't yet have all of the answers. So physicians are weighing many different risks and benefits. Every 5 or so years, the NMDP and CIBMTR publishes a recommended set of guidelines for donor selection. So a group of physicians and researchers across the country come together to review newly published research since the previous set of guidelines came out, just to help distinguish what we know from what we don't. So with advances in the field over the last few years, I think the key takeaway right now for donor selection is to really prioritize young donor age and availability. So using a strategy that considers all potential donors up front and not spending so much time waiting for that perfect 8 of 8 match to come around. Just pick the donor that is going to be available on the patient's timeline. Now, I don't expect you to read this slide, but to accompany the updated recommendations that were just put out last summer, we outlined a workflow to help physicians and coordinators to think through the process prior to the actual selection of potential donors. And so this just kind of walks you through all the steps you want to consider before you start selecting donors for your patient. And you'll notice a couple spots here are highlighted yellow to indicate program-specific decisions. And what this means is we just don't have strong enough evidence to recommend one path over another. And so some parts of selection need to be decided on at the transplant center level because, like I said, there are still many unanswered questions. And so that's why clinical trials are also still so important. We need to continue to enroll patients on clinical trials so we can collect the data and answer all of these questions that we still have. Now, I also don't expect you to read or understand anything on this slide, but I thought you might be curious to see what it actually looks like when we are looking at potential donors on the registry. Excuse me. It really is just, this is a fake patient, but patient information is at the top, and then it's really just row after row of potential donors that exist on the registry. And you can see all the different information that physicians and coordinators are looking at, what country is the donor in, and what is their age and sex, their CMV status, their blood type, their actual HLA typing, and so on. As you scroll across the page, there's actually more and more information on these donors. So as coordinators and the rest of the transplant team, as well as their support from NMDP, go through all of the potential donors, they narrow down the list to a few. You always want to have a couple of backup options identified because we are talking about humans, and not every human is going to be available when you need them to be. And so when they've narrowed down their list of the potential donors to request, they request them through this system, and that notifies NMDP, and then NMDP starts calling these potential donors. So I'm just going to briefly talk through a very simplified process here on my last slide. It all starts with donor recruitment. So for years, NMDP has been recruiting young, healthy donors to join the registry. And when a patient gets diagnosed with a blood cancer or disorder, the doctor then does the necessary testing to start a search for a matching donor. And typically, like I said, they're looking at both related family members as well as the unrelated donor registry. And then comes the donor matching. So when a potential donor is identified, NMDP contacts that donor. Like I mentioned earlier, they go through a health history questionnaire. They guide the donor through what the next steps are going to look like to confirm that they're ready and able to donate. And then they have two different ways to donate. Most of the time, donors are actually giving peripheral blood stem cells, which is a non-surgical process that's very much similar to donating plasma or platelets. Only about 10% of the time are donors actually donating marrow, which is the surgical procedure where cells are collected from the hip. And the patient's doctor is the one to decide which option is going to be best for their patient. And then on transplant day, patients receive conditioning, often chemotherapy, to prepare their body. Excuse me. The donor's healthy cells are then infused into the patient, much like a blood transfusion. And then comes engraftment. So the donated cells travel to the patient's bone marrow where they begin to grow and create new healthy blood cells, helping to restore the patient's blood and immune system. So with that, I will stop sharing and pass it off to Kiamara.
Hey, good evening, everyone. My name is Kiamara Gonzalez. I live in Georgia, and my son have a ALD. And I will share a little bit of his journey during the ALD process and the transplant process too. All right. Our ALD journey began on May 18, 2017, the day Jacob was born. A few weeks later, I requested an ALD test because I know I carry the gene because my brother passed away for the disease, for a late diagnosis. For 5 years, Jacob was under close monitoring with regular MRI and blood work, and you can see him dancing a little bit when it's his turn for the MRI. All right, on July 13, 2022 was when everything started. Everything changed on July 13, 2022. That was the day his neurology told us that Jacob had an active lesion. It was the most devastating day for our family. After that, there were many long days and a sleepless night. When we returned to Georgia, because his neurology is not here, his neurology is in Boston, I contact his doctor, who is here today in this webinar. I remember sending him an email explaining that Jacob have an active lesion and that we need option, we need an appointment. I was terrified because my son is a Latin boy, Hispanic boy, and I didn't know if he will have a donor match. Always was on the back of our head if Jacob will have a match because he is Latin. I told him I already has his HLA result because I requested test right after we learned he was ALD positive. Right away, I received an appointment for the following week, and the doctor asked me to send Jacob HLA result by email. And a couple days later, his nurse called me and said, "Don't worry anymore, he have a match." That was the bigger blessing during such a difficult time. During the appointment, his medical team explained everything to us, and together with Phi and Ho, we decided to move forward with a stem cell transplant using a cord blood. When his life began again, November 14, 2022, a stem cell transplant is not just a medical treatment for family like ours. It represents hope, it's chance for healing, for more time, for more memories together. During the transplant process was one of the hardest steps we have to face. On November 14, 2022, Jacob received his stem cell transplant, a day that carried more weight than words can fully hold. That morning, we asked the hospital chaplain to come and bless him. That moment brought a quiet sense of peace. It's something we still hold into a memory we will never let go of. After the blessing, we stayed in the room waiting for the cells. Time seemed too slow, every second stretching with hope, fear, and love all at once. For us, it was not another day, it was everything. As soon as the infusion began, Jacob had a sudden reaction, was a little bit scary, but doctor quickly rushed into the room to care for him, and it was super scary. Thankfully, a few hours later, he was doing better, bringing a sense of release. After that, we entered in a period of waiting for the engraftment day. Many nights were spent hoping and praying as we wait for update from the doctor. Jacob faced some difficult days due to the side effect of chemotherapy, but also too many good days for him to give off strength. And there is some picture of Jacob in his room. He was playing, it was rough day for him too, but his bed was making every single day with his blanket. He played with his kid. Always I call his dinosaur his kid. And happy. And we just was grateful for everything. His discharge day. Along this journey, we realize we are not alone. There are doctors, nurses, research, and donors whose dedication and generosity made this second chance possible. Because of them, family like ours can hold onto hope. That is Dr. Long, and he is there with the bell. And this is his life today. We always grateful with God, with the donor, with his medical team, with Dr. Long, playing soccer, playing golf, basketball, dancing, and doing his martial art. He is like a normal boy with this disease, but this disease is not stopping him for anything. I always told him he can do whatever you want in this life. And thank you.
Thank you so much to all of our presenters. Kiamara, thank you very much for sharing Jacob's story and your family's story with us. Um, Now we can go ahead and take some questions for everyone. So the first question is, how do you prioritize between matched sibling donors, matched unrelated donors, cord blood, and haploidentical donors?
Well, this is probably a question for me, but I might turn it to Dr. Lund on this because from my team's perspective, we work with many different transplant centers across the country, and every physician has different decisions, and there isn't one right answer. So, Dr. Lund, what do you think?
So I think there is some right answers. Matched sibling donors trump everything. Even today, as good as we are at transplant and having the best donors available, siblings will always trump. There's maybe a rare circumstance where the matched sibling is a baby and the recipient is like a large person. Because of that weight mismatch, maybe we would go to an unrelated donor. But if they're anything else, siblings are the best for us. The haplos in our ranking, we would put that in fourth place. We prefer unrelated donors and cord blood before haplos, though we can do haplos and have a protocol. So that's kind of our hierarchy. It's match sibs, the other two, and then kind of haplos, but everything else is available.
Thank you. The next question is, what are the key risks associated with different donor sources? So all of those donor sources that you just went through, matched SIBs, unrelated matched donors, cord blood, haploidentical. And specifically also, how does graft versus host disease factor into donor choice with those four and the risks?
Well, so some of the risks, the two big risks are A, graft rejection or graft failure, and then B, graft versus host disease. So they're kind of opposite ends of the same, two sides of the same coin. So in graft versus host disease, the graft is working well enough where it attacks the body. This is the rate of graft versus host disease is center dependent, depending on the chemotherapy. And so our rate is exceptionally low in our protocol, but also it is dependent on the amount of matching. And so so as the matching goes down, you have a higher rate statistically of GVHD. So like the 6 of 8 match is going to have a higher rate than an 8 of 8 match. So that's how that works. Graft failure kind of works in the same regard that if the graft doesn't take, it's more likely with a mismatched graft. So like a 5 of 6 or 4 of 6 or a 5 of 8 graft sometimes can have more graft failure. It's interesting that you can have this two opposite problems because of that mismatch, which is why finding the right donor is so very important. And the more we have to choose from, the better. Now you could say, well, then how come haplotransplants work? Well, haplos use an entirely different process and protocol, but they do still do have some risk of GVHD. So, but that's kind of how it works in a nutshell with a big painted brush.
Great, thank you. And next question is, how does the urgency in ALD influence the donor search and decision-making process?
That's a good question. That's right. Kelly, what happens when we type in ALD donor search ASAP because they have an active lesion and it's not something we can wait on. There are diseases where transplant can be kind of moved down the road. Like you can say, well, why don't you, I think you're ready for transplant. Why don't you come back in June? There are definitely diseases like that. ALD is not one of those diseases. So what happens, Kelly?
Yeah, so we actually have, it's possible in our system for the coordinators who are working closely with the physicians to enter a transplant timeline. And that gives us indication of how urgent is it. And we see a lot of urgent cases, in which case we are very much prioritizing US donors. We also tend to prioritize our own NMDP donors. So there are a couple different US registries that show up on the main system where you can see all potential donors. And of course, NMDP has more control over our donors. We can quickly pick up the phone and start calling many of them. And we go through that process really quickly to identify, are you available like in the next 2 weeks? And we get the information we need. So I would say that's the biggest factor. When we see that there is urgency, we immediately hone in on the US donors, specifically NMDP donors. But cord blood is also a really great option for that because cord blood is essentially off the shelf. And so you're not dealing with a human who has a life and has conflicts. So.
Thank you. Um, and then just to clarify, what is the typical donor search timeline like from the time when you enter into the database, we need a match to the time when a match is typically found, if there is a standard time for, I guess, ASAP requests versus non-ASAP requests?
I would say me and Dr. Lund should both answer this because I'd be curious to hear from his perspective. So I will admit I'm only on one team at NMDP, and like I said, it takes lots of teams to keep everything running at NMDP. So, our my team's process of helping to select the donor kind of comes to a stop and another team begins to take over. But that timeline can really vary. I mean, excuse me. We can get a patient entered into the system. We can start looking for those donors and calling them on day one. But then, you've got to get that donor scheduled for an appointment because they have testing to be done. And so just all of the logistics of everything is going to vary. Um, so honestly, I don't actually know the right answer on like if it's urgent, how quick can we really do it? Probably the fastest is maybe within a month, but I'd be curious to hear what your experience is like, Dr. Lund.
Yeah, that's really close. Cord blood, we can say 2 to 3 weeks because those are donors sitting in freezers all around the country and they're ready to be thawed and sent to us. Unrelated donors, the fastest we often quote is 3 to 4 weeks because of, the physical exam and the donor clearance. Sometimes we're finding donors farther away, like South America, and then we have to say, well, it might be 4, 6, or 8 weeks is about as quickly as we can get it done. Obviously, we shoot for that 4 week mark if possible.
We did actually have a similar question about the international donor situation. So I'll jump to that question next. Is NMDP involved in international matching? There was a family who submitted a question who's currently in Australia, and they were wondering, for example, if there was a match found in the United States, would it be an option to fly the donated cells to Australia? How would that process work, and what would be the risks, for example, to the cells if that happened?
Mm-hmm. Yeah, it is an international process. So I can speak from the perspective of US transplant centers, like Dr. Lund's team would look at all potential donors that are on any international registry that exists. They're going to show up on the search results for any given patient. And so every day we are shipping cells internationally. And so it is very common. Of course, the longer it takes for cells to get from point A to point B can impact the quality. But it happens all the time and I don't think it is too much of an issue, but
Mm. Kelly, do you know if a transplant center in Australia can use a United States donor bank and
I,
receive the cell the other way?
yep, I think so.
It's
Yeah.
all collaborative.
Mm-hmm. Yep.
Okay.
Okay, great. Glad to hear that. The next question is mainly for Dr. Lund. How would you counsel families when time is limited and there are not ideal options for a match?
How would I counsel them? It's a good question. So, what I try to tell, well, the first thing I often tell families is matching is an opinion. There's science behind it, but it's often opinion because a physician may say, well, you don't have any matches. But if you come to me and I would say, I look at the registry and sure, there's no perfect matches, but you have plenty of other matches. And if your chemotherapy and GVH medicines are the way you want them and dialed in, you can actually use those donor sources. So, for instance, 7 of 8 would be fine, maybe even a 6 of 8. A 4 of 6 cord can work in our hands. The next thing I discuss is gene therapy as an option. The third thing I discuss is almost everybody has a parent, and this is the exception would be if you're adopted, which does happen. But most everybody has a parent, and a parent would be a haplo match. So we can go down that road as well. So I kind of go through all the options and the levels of matching, and what we can do.
Great, thank you. And we have a next two related questions. First, from a parent, how can I find out if my son has a match in the registry? And then, related question, do you advise boys to get HLA typed as soon as they're diagnosed with ALD to save time if cerebral ALD were to start?
I do. I type everybody who wants to be typed, even newborn babies or babies that are, logically 3 or 6 months old, because the parents like that peace of mind to know who's in the registry for cord blood and unrelated donors. So I will type everybody who comes to my clinic.
Okay. Um, Next question is, can women who have ALD, who have one variant in the ABCD1 gene, or individuals for other disorders who are carriers, are they eligible to become donors in the NMDP registry? And specifically, are they eligible to donate to an ALD patient for transplant?
So you'll have two answers. I think I'll have an answer and Kelly will have an answer. So I have no problem using siblings with ALD as a donor. Because as I started off, sibling transplants for me trump everything. And just because you use females' blood cells who have one X chromosome with ALD, we've done it several times at least, and their outcomes are identical to normal healthy donor outcomes. So when it comes to using the sister, basically, I have no problem doing that. Other centers may say no, but I say yes to that. And then, as far as adult donors, that goes over to Kelly with the intake form and the physical exam and how they determine who has what.
Yeah, I can't speak too much about this. I know that donors have to go through a very lengthy health history questionnaire when they initially get that phone call from NMDP, and that catches a lot of what is going to prevent a donor from providing their cells to a patient. And then they go to a physical exam, and get testing done. But I don't think I have anything different to add than you. So.
Great, thank you. And then our last question for all three of you is, what is one key takeaway you want families to leave this webinar with?
Well, for me, I think that one key takeaway is, always have hope that there are plenty of donors out there for most families, and we'll do the best we can to find the best match for you. And transplant outcomes can be fantastic, even with less than perfect matches. Though we always need more donors, which is kind of Kelly's role. So I'll let Kelly, state what they really need.
Yeah, I mean, I would say the same thing that we really feel today, like just about any patient can find a potential donor. So it's, knowing what questions to ask your transplant team, making sure, if they tell you there isn't a match, like Dr. Lund mentioned, do they do cord blood? Because it should be very simple to find a cord blood unit, especially for a child. So I think that's also my takeaway.
And Kelly, are there specific populations where you really need more people interested in donating?
Any of the ethnically diverse. I mean, Kiamara, when you mentioned you have Latin background, these are the populations where we do need more donors. If you are white, you're probably going to be able to find a perfect match. If you are Black, you're Hispanic, Asian Pacific Islander, these are all the populations where patients have a harder time finding a match.
Yeah, and I can say the same, like Dr. Lon and Kelly. We have option, and thank you God for that. We have option with cord blood. I mean, I was scary, like what I said before, because Jacob is Hispanic. But when I received that phone call that day for Nicole, I was blessing when she told me he have a match.
Great. Well, thank you to all three of you for taking the evening to answer so many questions and to share your wisdom with us. And thank you to all of our attendees today for being here. And I'm glad we ended on such a nice note of optimism. I hope everyone has a wonderful evening and was able to learn something tonight. Thank you all for joining.
Thank you.
Thank you.